Good afternoon, everyone. Before we start, I would like to confirm who are all here, the presenters. Sanjuktakar, good. You can come in the front. No questions will be asked. We will ask you questions on the dais, not there. Saloni, Dr. Saloni, she there? Yes, please come in front. Reshma, Dr. Reshma, please come in front. 3. Dr. Akshat Jain, 4. Good. Parul Sandhwani. Dr. Come in front. Dr. Sai Tejasvi Gopalakrishnan. You there? Deepthi, Dr. Deepthi, you there? Yes. Dr. Manasi, please come in front. Dr. Samarpita Dhar. Dr. Samarpita Dhar? No? Okay. Akshay Kumar? Dr. Akshay Kumar? No. Dr. Mohan Krishna Reddy? Yes. Dr. Sarbraj Nag? Good. Dr. Aruja Gangwani? Dr. Aruja Gangwani? No. Dr. Shrija? No. Dr. Rishabh Narula? Okay. We'll start. Okay, we still have 3 minutes of introduction. I am Dr. Santan Gopal.
A very good afternoon, everyone. I hope I am audible.
You can use this mic.
Yes, it's working. So, a very good afternoon, everyone. We welcome you all for the PG capsule on Squint and Neuro-Ophthal. We expect that the session will be extremely mind-blowing and we'll be discussing a large number of cases. I am Dr. Gunjan. I am Squint and oculoplasty specialist. I'm currently practicing in Bhilai, Chhattisgarh. I've done my MD and senior residency from RP Center AIMS. Sir needs no introduction. Sir is Professor Santan Gopal. Sir is presently practicing in Bangalore, and Sir also has done his MD from prestigious RP Center and has done a large number of work in Squint. And latest is the Sir's orthoptic, which we would like to hear also from Sir in later part of the session as for the cases.
There is an instruction course tomorrow at 1:30 about orthoptic. It will change the entire concept of Squint. Okay, we'll start with the first speaker. Yes, come, please come. Dr. Sanjukta, you pronounce J or you don't pronounce J, like in Spanish? Pronounce.
Due to tuberculosis.
Yes, start.
Good afternoon, everyone. Today, myself, Dr. Sanjukta Kaur, junior residency. I'm doing junior residency in ophthalmology in Calcutta National Medical College, Kolkata, with my co-author, Dr. Partha Sharathi Roy, associate professor of Calcutta National Medical College, Kolkata. We'll be presenting a case of atypical optic neuritis due to tuberculosis. The patient came with a 28-year-old female patient, presented with dimness of vision, left eye, for the last 7 days, the onset of which was gradual and painless in nature. She has a past history of being admitted in chest department 1 month back, where she was diagnosed with pulmonary tuberculosis, and ATD was started, and she was discharged with an advice to attend AIOPD for her visual symptoms, which started merely 3 days before discharge. On examination, in the right eye, visual acuity was 6/6. In the left eye, it was 6/36, which improved to 6/18 with pinhole. Anterior segments of both the eyes were normal. RAPD was present in left eye. The color vision, right eye was normal, but she could not interpret and read some colors and patterns of Ishihara's chart with the left eye. On fundus examination, right eye was normal. Left eye, VCDR was 0.3 to 0.4:1. Macula normal. Disc margin was nasally blurred in the left eye. This is the fundus picture of the left eye showing the blurred disc margin. We went for the following investigations in which the VEP was prolonged with P100 latency in the left eye. We did contrast sensitivity, perimetry, OCT, RNFL was done. The MRI brain showed right frontal lobe infarct, and HRCT thorax showed hilar lymphadenopathy with bilateral upper lobe mixed density lesions. Blood work were done, which are all within normal limits. Serology was non-reactive. Chest X-ray PA view was done, and her sputum AFB came to be positive. This is the VEP picture showing prolonged P100 latency of the left eye. And this is the chest X-ray of the patient, PA view. In the management, patient was started ATD in the chest department. My provisional diagnosis is atypical optic neuritis in a case of pulmonary tuberculosis. Now coming to the summary of the case, a 28-year-old female patient presented at IOPD with dimness of vision in the left eye for the last 7 days, the onset which was gradual and was not associated with pain. She was admitted in chest department where she was diagnosed with pulmonary tuberculosis and ATD was started. On discharge, she was advised to attend the IOPD. These are the differential diagnoses, which are AION, chronic papilledema, severe systemic hypertension, orbital tumor compressing optic nerve, Leber's optic neuropathy, toxic optic neuropathy, and intracranial mass compressing afferent pathway. My take-home message is, it is emphasized in this presentation that atypical optic neuritis should be differentiated carefully from typical optic neuritis. Any deviation from the features of typical optic neuritis should arouse the suspicion of atypical optic neuritis, and battery of tests should be done to unmask the diagnosis, which in most cases is infective in origin, like tuberculosis in the present case. Thank you.
What were all the atypical features in this case?
So here my patient,
Before we go to atypical feature, what do you think are the typical optic neuritis features?
in the typical optic neuritis, there is pain on eye movement.
Okay.
And there is gradually, on starting of the treatment, there is improvement in vision. And there are normally no fundus specific findings are not present in typical optic neuritis. And it affects...
It depends on where is the optic neuritis. If it is RB neuritis, you may not see anything.
Pardon, sir?
If it is retrobulbar neuritis, you may not see anything.
Yeah.
Isn't it?
Yes.
Yeah.
The optic disc appears normal in retrobulbar.
Yeah.
One more thing you told us, that there will be a response to treatment on starting it. Sometimes it just improves spontaneously. Even if you don't start any treatment, it is going to improve. It was not a, you are stating that this was in case of atypical optic neuritis, but if you see, the patient's age is 27. She's relatively...
Yes, the age is not matching, and
she's
the
relatively
gender
young.
is also not matching. Just like
but-
there was no pain.
But pain is not an essential feature of optic neuritis. It may or may not be there sometimes. Secondly, one more thing.
Even if you see the pain in optic neuritis, when do you see most often in optic neuritis? Which eye movement causes more pain in optic neuritis? Elevation, abduction, adduction, which movement of the eye causes and why?
The medial rectus and the superior rectus when gets
Medial and
involved.
so looking inwards and looking up causes maximum pain because that's where the thing is closely attached to the
The
meninges.
meninges. Okay. Okay.
So you ask the patient to look up and medially, if there is pain, that's one. Second important point is retropulsion of the globe causes pain. If you press the globe backwards, it should cause deep-seated pain. That shows that it is most probably.
Yes.
The third feature is RAPD. Yes?
Then, what were the MRI findings in your case? You didn't discuss much. That
There were
in detail.
infarcts.
There were infarcts. And
Yes.
what about the optic nerve as such? Was there any enhancement?
No.
No. There was no enhancement of the optic nerve. Okay, that is quite unusual.
Unusually.
Because optic nerve usually enhances if there is an inflammation. Then did you do any CSF analysis in this case?
No CS analysis.
No, that should have been done to
That should have
label
been
it
done,
completely as tuberculosis. Because it can also be toxic optic neuropathy at times due to drugs like ethambutol and isoniazid. So I think CSF analysis should have been
done.
Sir, what do you suggest?
They should have done CSF.
Yes, and third thing is, if your case has an atypical optic neuritis caused due to tuberculosis, as you have tentatively diagnosed, I think steroids along with ATT should be started.
But the only difficulty is in assigning this to the tubercular cause. This could be a separate etiology altogether, not related always to tuberculosis.
That's why CSF analysis would have been more conclusive.
More useful in this case. Okay, that's additional take-home measures for next time presentation. Okay? You can go. Well done.
Thank you, sir. Thank you.
Dr. Saloni. That's why I said you come in front, otherwise you'll have to run. Reshma, sit in front.
Good afternoon, everyone.
Come.
Respected faculty, I'm sorry we have two atypical optic neuritis right one after the other. Mine is a case of a drug-induced optic neuritis, which is rituximab-induced optic neuritis. So in our case, we had a patient who is a known case of mantle cell lymphoma, and he had orbital non-Hodgkin's lymphoma, which is mantle cell lymphoma, and he was on treatment with the standard therapy, which is our job, rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisolone. But this patient, he had orbital symptoms since he was a known case of non-Hodgkin's lymphoma since February 22, and since the beginning of 2023, he had swelling in both of the orbits. The picture on your left, and he was on rituximab therapy, and during a cycle of which he had exacerbation of symptoms, which is increase in periorbital swelling and diminution of vision, with the complaints of which he presented to us in the month of December 23. And this was noticed right after his second cycle of IV rituximab. So on presentation, the patient had a picture like this, which is the picture to your right. So on presentation, the visual acuity of the patient in the right eye had only 1/60 vision. In the left eye, there was no perception of light. There was severe restriction of extraocular movements. The intraocular pressure was raised as well in both the eyes. There was a firm swelling in the orbital region, and there was REPD, presence of REPD in the left eye. And the fundus picture, the discs appeared normal bilaterally, but in the left eye, we were suspecting that the patient might have CRAO, and together with the orbital picture, we were suspecting that the patient might have an orbital compartment syndrome as well as optic neuritis, because we ran the color vision of the patient was significantly affected, and as was the contrast sensitivity, and we got an EVR done as well. On MRI, we found that there were enhancement along the optic nerves, along with the soft tissue enhancement and the sign for raised intraorbital pressure, which is the tenting of the globes, which is seen in this particular scan. So we started IV methylprednisolone for the patient, 1 gram for 3 days, and we saw a dramatic response. The patient's, sadly, the visual acuity in the left eye, it did not improve, but in the right eye, the patient slowly gained vision, and he gained up to 6/24 in the right eye. The pressure were also, intraocular pressures were also normal in the follow-up period. The patient gained full and free periocular movements. So, some background to this, the flare-up of orbital inflammation following rituximab therapy has been reported in several autoimmune conditions and as well as malignant conditions like the antiphospholipid syndrome, Graves, even in neuromyelitis optica where rituximab is routinely given, it can cause a flare-up of the orbital inflammation. So the normal, even in this patient, rituximab therapy was combined with intravenous hydrocortisone, but what we like to argue is that that cover might not be enough to safeguard the patient from these flare-up of inflammation. So the stronger, higher potency steroids, such as IV methylprednisolone and a higher dose, are warranted in patients, especially those which we know have a greater involvement of the orbit, or patients which have peri-optic nerve involvement. So a close follow-up of patients on IV rituximab is warranted. The follow-up is warranted, and the need for IV methylprednisolone should be considered in all patients. Thank you.
Yes.
So, thank you, Dr. Saloni, for that well-documented case. I would love, were you sure that it was rituximab only that was the culprit of optic neuritis in this case? Because as you also told us in the presentation, and we very well know that it is sometimes the last resort we turn to in patients with neuromyelitis optica. So, are you pretty sure was enough investigation done? Why optic neuritis is not said to be a part of that autoimmune disease which the patient already had?
Right, ma'am. Ma'am, the previous pictures I showed, like the patient was a known case of non-Hodgkin's lymphoma, and he had orbital involvement since the starting of the year, like in January 2023. And his flare-up began in November, and rituximab was started in response to that. So on initiation of the therapy with IV rituximab, there was a flare-up of both the orbital disease as well as diminution of vision, which was so drastic, and coupled with our MRI findings, we made a provisional diagnosis
So
of
basically it was not just optic neuritis which happened, it was also a flare-up of the orbital
Orbital,
involvement
right.
of your Hodgkin's lymphoma that had occurred, right?
Absolutely.
Non-Hodgkin's lymphoma. So was any biopsy done in this patient before starting the treatment?
Yes, ma'am. We actually did a biopsy before, in November, the patient underwent biopsy of the orbital mass, and it was positive for lymphoma.
And what about the markers? Was it CD20 positive? Because rituximab is something which is
Right.
going to act only on CD20 cells. It's a monoclonal antibody.
Right, ma'am. Actually, the tumor was positive only for cyclin D1, and the markers which are specific for DLBCL, the specific test for CD20 was not actually done. But as a last resort, patient was given rituximab.
Okay.
Okay, good.
Thank you, sir. Thank you.
Dr. Reshma.
So I think Dr. Reshma will be discussing about pediatric optic neuritis.
So good afternoon, everyone. Today we'll be discussing a case of pediatric optic neuritis. So briefly, an introduction. So optic neuritis refers to the inflammation of the optic nerve, typically associated with multiple sclerosis and visual loss over hours to days, with an adult of around 1 week. So, and typical age of onset is around 18 to 45 years. And so here we'll be discussing a pediatric optic neuritis. And this is a subset where the age of presentation is less than 18 years. And usually we see atypical features of adult ON in pediatric optic neuritis. So mostly bilateral presence of this swelling follows a viral infection. And literature shows a female predilection and also MOG antibody seropositivity is noted to be higher. And they are also mostly steroid sensitive with good visual prognosis. So we had a 11-year-old male who presented to our pediatric emergency with complaints of sudden onset, rapidly progressive vision loss in the left eye over the past 10 days. He also gave a history of ocular pain, like mild intensity, behind his eye, concurrent with the starting of the symptoms, lasting for around 3 days. And he had no other significant history, like no other similar episodes in the past, no similar complaints in the other eye, no history of any trauma preceding the onset of symptoms, no history of recent viral illness, recent vaccination. And most of the other history we probed were pretty negative. And birth history, the only significant history was that there was a history of neonatal admission because of jaundice and also birth asphyxia. And immunization history, he apparently misses vaccine at 10 years of age, most likely TT, they were not sure which vaccine. So on ocular examination, right eye was completely normal with a visual acuity of 6.6, and left eye was PL negative on presentation, and pupil was noted to be 3 mm sluggish, grade 3 RAPD. Fundus, media was normal. The disc had some changes. It appeared slightly hyperemic. There was a mild elevation of the disc margin, and a single splinter hemorrhage was noted in the superior disc margin. Otherwise, completely normal. Extraocular movements were also full free, and no pain was noted on movements. So further, we investigated the patient. So MRI imaging was done with contrast, and we noted that the left optic nerve was appeared like there was hyperintensity in the retrobulbar area, intracanalicular and cysternal segment, and it was also extending up to the optic chiasm. And the maximum thickness was noted in the retrobulbar area. And further blood investigation, other investigations showed that MOG was strongly positive, NMO was negative, and we, since it's a pediatric case, we also did extensive workup to rule out any infectious causes, which all turned up negative. So this is the fundus image showing the splinter hemorrhage. So this was a combined effort with our department where we had suggested MRI. Then further, we also asked to start on high-dose IVMP after clearance from the other departments, and baseline investigation was done. And we serially monitored the patient through the admission. And pediatric department, they were the ones who had sending the appropriate lab investigations to arrive at any etiological diagnosis we could. And further, neurology had advised NMO and MOG, and that's when we found MOG was strongly positive. And they planned for PLEX if there is a plasma exchange if the vision did not improve satisfactorily. Finally, the diagnosis we came to was atypical pediatric optic neuritis with MOG antibody positivity. So intervention, we started on IV methylprednisolone, 1 gram per day, was given 5 days. The child was monitored clinically and neurologically, and there was no evidence of any neurological deficit or any other positive symptoms through this day. And we further switched over to oral steroids. So outcome was on day 2 of starting the steroids, the child started noticing, there was a perception of light noted in the left eye. Day 4, there was hand movements close to face was appreciated. And further at discharge, it remained hand movements close to face. And on follow-up, we reviewed after a week of steroids, and that time was counting finger at 1 meter. And the second follow-up, which was a month later, was around counting finger at around 1.5 meter. So just briefly on literature review. So prognostic factors with poor visual outcome was noted in a study by Delphine et al. That is like age more than 10, optic disc pallor, and multiple sclerosis. And there's an important study, the pediatric optic neuritis prospective outcome study, which noted that MOG-associated ON had lower risk of poor severe visual loss and recurrence. On the retrospective analysis showed a better visual recovery at follow-up and lesser chance of relapse in MOG-positive patients. And there's an Indian study, a retrospective analysis, which showed that if there's profound visual loss and presentation and bilateral involvement, they usually had poor visual outcome. And there's a similar case report to our study with a monocular blurring of vision and similar findings, and that child had an excellent visual acuity recovery. In fact, that child had 6/6 recovery and normal color vision at the end. So the clinical implications of my case would be that one is that pediatric optic neuritis is actually a relatively rare and less studied as compared to other adult ON. And so more large-scale studies, especially long-term prospective studies, would be required to to decide treatment. And the current treatment guidance actually are derived from the ONTT trial. So, yeah. And also, MOGAD, the optic neuritis, has a better visual outcome according to studies. So, it is vital to obtain imaging antibody marker tests at the earliest to determine the pathway of treatment.
Okay, thank you. Since this is a PG capsule, it's important for you PGs to understand that when you are making the slides, do not put more than 4 lines per slide. If a 4-minute talk, the total number of lines should be 16 in 4 slides. And you should practice conveying accurate information of what you want to say in those 16 sentences. Okay? Otherwise, many people lose interest. If you put the whole page of Harrison in one page of one slide, nobody has enough time to read, and you cannot sit and read all the information. So make only 1, 2, 3, 4 points per slide. And 30 seconds should be maximum time per slide. You understand? Good. Pediatric optic neuritis is extremely rare. I would say I have seen about 4 or 5 cases till now in my entire ophthalmic career. So it is quite rare.
It is rare, and it is sometimes tricky also, because it is not 1+1. We cannot go according to ONTT trial. They need a lot of investigation. It can be because of tuberculosis. It can be something atypical also. Sometimes we do get surprises. And yes, so MOG antibody was positive in this patient.
Yes.
So definitely they are notorious. Actually, MOG, once you get positive, you need to be more careful because they are notorious for recurrences. They will respond very fast, but they will recur very fast.
Yes.
So that is what you have to keep in mind, and sometimes these patients might need to be kept on long-term immunosuppressants also. So that is one thing which I just would like to add in this, otherwise it's okay. Thank you.
Want to ask anything? Dr. Akshat Jain.
He will be talking about retinitis post-febrile illness with optic neuritis.
He's not there? I thought he was there. Akshat Jain? Yes. All right.
So, a very warm good afternoon. So I would be discussing about the retinitis post-febrile illness with severe optic neuritis. So what we already know is that the post-febrile retinitis is very common in the tropical countries like India and mainly caused by viral or bacterial agents, and it can rarely be associated with optic neuritis. However, the patient presents to ophthalmic clinic generally 2 to 8 weeks after the onset of systemic symptoms, and the treatment aims at 2 modalities. One is to target the infectious organism and other to control the inflammatory reactions. So jumping to the case, our case was a 13-year-old male. He presented to OPD with the chief complaint of left eye loss of vision since 10 days. He had a positive history of fever 1 month ago lasting for 3 days. However, there was no history of any skin rash, joint pain, oral ulceration, cough, recent weight loss, or travel to forest. The right eye visual acuity was normal. However, left eye visual acuity for distance was counting finger close to face, and near visual acuity was less than N36. On torchlight examination, he had a grade 2 RAPD in the left eye. The external examination was grossly normal, and anterior segment examination on slit lamp was also unremarkable in both eyes, with intraocular pressure being 15 and 17 millimeters of mercury measured by Goldman applanation tonometry. The post-dilated examination of right eye was unremarkable. This is a colored fundus photo of left eye showing a medium-sized hyperemic disc with cup disc ratio 0.3:1 and a whitish fluffy retinitis lesion with vascular exudates along both superior and superior tempora and inferior tempora arcades with a curve of subretinal fluid and macular edema. However, this fundus finding does not correlate with the vision of counting finger close to face. So something else is still happening. This is a OCT picture of left eye showing a diffuse retinal thickening with the inner retinal layer hyperreflectivity and inflammatory hyperreflective dots. On the right of screen is a delayed phase fundus fluorescein angiography image showing retinitis lesion with central hypofluorescence and perilesional hyperfluorescence. So, as we suspected something more than a fundus pathology, so we went ahead with the MRI, and as expected, he had a hyperintensity of optic nerve of both sides, that is bilateral retrobulbar optic neuritis, and on blood test he had a raised ESR with neutrophilia. However, the serology for infectious agents were negative. Rubella and CMV had IgG positive, but they had very less sensitivity. So a diagnosis of left eye retinitis post-febrile illness with bilateral retrobulbar optic neuritis was made. So the treatment was started covering the trial of steroid, beginning with intravenous methylprednisolone 450 milligram for 5 days, followed by tapering oral steroid starting from 35 milligram under the cover of empirical antimicrobial treatment of antiviral and antibacterials. So this is a daily clinical chart, and as can be seen, after the fifth dose of IV methylprednisolone, the vision improved to 20/40, with color vision being 21 out of 23 Ishihara chart. So at the time of discharge, after 6 days, a resolving retinitis lesion, macular edema, SRF, can be seen correlating with the OCT findings. So reviewing the literature, the first article is a review article of published in Indian Journal of Ophthalmology that discussed about the post-febrile retinitis and the specific microbial investigation, while the second is a retrospective study in the RP Center AIMS, which discussed 19 eyes of 13 individual and discussed about OCT features and various treatment protocols. So final follow-up visit, the patient recovered almost the full vision, and the clinical implication is of my case is that the retinitis post-febrile illness with significant or out of proportional visual loss always suspect retrobulbar optic neuritis that can be both unilateral and bilateral, can be confirmed on MRI, and the pulse steroid can salvage the vision in post-fever retinitis optic neuritis given with the cover of antimicrobial therapy. Thank you.
Thank you, Dr. Akshat. Thank you, Dr. Akshat. In this part of India, we also came across this type of cases, not very frequently, but sometimes. But over and above, the exact etiopathogenesis is obscure. We also follow the same sort of treatment regime and got beautiful visual outcome after about a couple of months or so.
So you showed us OCT of the retina where there were exudates. What about OCT macula? Was it normal?
OCT macula was also there. It has the subretinal, the neurosensory detachment and subretinal fluid mainly.
Okay.
It because of the retinitis going on along with optic neuritis.
Okay. Because the vision, you were, so I must congratulate you and the consultants who were dealing. It was a nice case, and it has been well documented also. Angiography images were also very nice. Only thing was, yes, you should raise a suspicion when you do not correlate the vision with the findings you are seeing. Even if there is a cuff of fluid in the macula, the vision cannot be finger counting or 1/60 or PL positive. You need to think that it might be something beyond. So always keep your mind open. Don't just go forward with the treatment. Okay, it might be just because of the retinal pathology. Sometimes, yes, optic nerve pathology, as in this case, can be associated along with the same. So
Also the RAPD.
yes, RAPD component was also there, but sometimes in the initial stages there can be just grade 1 RAPD. It might be very subtle and you might just miss it in a heavy OPD. So just correlate the vision with whatever you are seeing.
Dr. Parul is not here? Yeah.
Yeah.
Dr. Sai Tejaswini, be ready here.
So Dr. Parul Sadhwani will be discussing a case of neuromyelitis opticum spectrum disorder and the role of hormones. Okay, so I think there is some technical issue. We can move on to the next speaker for
Dr.
the
Sai.
time being. Dr. Sai, lower motor neuron facial palsy.
Tejasvi Gopal Krishna.
Am I audible now? Yeah. Okay. So good evening to everyone present here. My patient is a case of low motor neuron facial palsy with traumatic optic neuropathy. So my case will be discussed under the following headings. So my patient is a 31-year-old IT professional who presented with complaints of difficulty in closing the left eye with blurring of vision in the same eye for the past 2 weeks. So the patient was apparently normal, after which he encountered a road traffic accident while traveling on his bike in the early hours of the morning. He has actually no recollection of the incidents leading to the accident. According to his informant, he was found unconscious on the side of the road and was taken to a multi-specialty hospital for further management. So he was found to have sustained multiple injuries to the head, face and abdomen, and also to the left arm. And he underwent abdominal and facial surgery on the same day. And for the left arm, he was treated with a POP cast, and he was unconscious for up to 1 day after the accident. So following recovery of his conscious, he found that he had difficulty in closing the left eye associated with increased watering in that eye, for which he was prescribed eye drops. And he also noticed that there was blurring of vision in the same eye a few days later, and it was not associated with pain, redness, or discharge in that eye. There was no associated deviation of the eye or double vision, and no history of fever, hearing difficulties, or weakness of the other limbs. So he had no significant optical history, and his systemic history was normal. So general examination, he was found to be normal. He had normal vitals. So central nervous system examination, his higher mental functions were normal. Other cranial nerves were normal. 2 to 7 will be examined. Motor, sensory, and cerebral signs were normal. Systemic examination was normal. He had an abdominal surgical scar. So in this patient, his head posture is normal. He had a contusion and a linear scar over the left side of his face. There was absent wrinkling of his left forehead. Left brow was a slightly lower level in comparison to the right, and there was slight narrowing of the left palpebral fissure. So lag of thalamus of the left eye was seen along with Bell's phenomenon. An obliteration of the left nasolabial fold was seen. He had deviation of angle of the mouth to the right side on baring of his teeth and inability to puff the left cheek. So his Hirschberg corneal reflex was centered in both the eyes. Cover test was orthophoric and extraocular movements were normal. So visual acuity was 6.6 in the right eye, and the left eye he had 6.9, which was not improving. He had no refractive errors on retinoscopy. His color vision was normal in both the eyes, and his intraocular pressure was also normal. So the right eye examination was normal, just that the pupil was sluggishly reactive to consensual light reflex. And the fundus of the right eye was also normal. So coming to the left eye, he had a small subconjunctival hemorrhage. His cornea was clear and with intact corneal sensation. There was no epithelial defects on staining with fluorescent. Anterior chamber and iris were normal. Pupil was sluggishly reactive to both direct light and briskly reactive to consensual. And on swinging torchlight test, he had a grade 1 RAPD. So the left eye fundus showed disc pallor over the temporal quadrant. His vessels, background, and macula was normal. So based on this, a provisional diagnosis of left lower motor neuron type of facial palsy with traumatic optic neuropathy was derived. We did a visual field on his left eye, which showed a superior hemifield defect. The right eye was normal. Neuroimaging revealed thickening of the optic nerve suggestive of traumatic left optic neuropathy.
Thank you for the case. Dr. Sai, I would like to ask, what was the exact site of fractures the patient had? Because
So,
we have not seen the CT images
Yeah.
before the surgery at
Yeah.
the time of trauma.
So basically, when the patient came to me, he was post-surgery. So they have already done surgery on his facial fractures. He had multiple maxilla, ethmoid sinus, and orbital floor fractures, all of which were repaired when he came to us.
Okay, so you didn't have the CT pictures?
No,
also?
just
Okay.
that he had the CT picture pre-op and post-op. So post-op, everything was fixed basically. The orbital floor fracture was operated on, and
So actually those pictures could have added
No,
more
he,
information?
he did
to
not
the-
have the pictures. It was
Okay, he didn't had the films.
he didn't have the films. He just had the report, so I was not able to get it.
Okay, so how do you explain the presence of facial nerve palsy in this patient?
He had a very gross maxillary fracture, so the probable site of the involvement of the seventh nerve will be at about its exit in the xylomastoid foramen. That is what we are suspecting.
Okay, and why was there a traumatic optic neuropathy then?
My probable guess is it's an indirect traumatic optic neuropathy, just that the force of the fracture would have caused a shear stress on the optic nerve, and that would have caused the optic neuropathy.
And then what was the management that was done for this patient?
Uh,
Because the last CT image that
had
you
a
showed
thick-
us,
Yeah.
it was showing a grossly
Thickened.
enlarged optic nerve.
Yeah, so he was referred back to his neurophysician, and he was started on steroid therapy. He's doing pretty well now.
Okay, I think for starting steroids, you could yourself have started him.
No, he was already on steroid therapy when he came to us. They just referred him for his cornea workup.
Okay.
So we just had to take a look at the cornea.
So what is his, did he come for follow-up? What was his final visual acuity?
His final visual acuity is still 6.9. It's just been a month since he last came to us, so we are waiting for the vision to improve.
Okay, so I think, okay, thank you for answering. So do you want to ask more?
No, the most important thing in optic neuritis you look for is red color desaturation.
Yes.
That's the first thing you look for.
Yes.
Now, simplest way to do it in outpatients
Bottle caps.
is timolol usually has red
Yes.
top,
Sir. Yes, sir.
correct?
Eye drop bottle caps.
Eye drop. So you ask the patient to first look at the top of the timolol drop with the normal eye, and suddenly change it to the abnormal eye and ask if the color remains the same or there is a difference in the saturation of the color. 99% of the patients will be able to identify the desaturation. So the red seed desaturation, you don't need to go and look for Ishihara charts. It may not be available here and there and things like that. Simple clinical test is to look for the thing is they should know what is normal. Therefore, you cover the abnormal eye and ask them to see with the normal eye, the red top. And then quickly switch over to the abnormal eye. When the brain remembers the degree of redness with the normal eye. Then they notice the difference in the saturation of the color. That proves immediately to you there is a red desaturation which is very typical of optic neuritis of any cause. That's very typically seen in all cases of optic neuritis. Am I right?
Yes, definitely.
See, so was any other therapy given to him along not only steroids or anything else was taken care of?
We have already advised him about taping, and we have given him lubricants. Facial massage was already initiated. The facial physiotherapy was already initiated at the primary healthcare center. Other than that, nothing much.
So
Okay.
basically, my suggestion for the postgraduates is for the case presentation, and if you are planning to report any case, I think you should have a very good documentation of the case. I know that you know, okay, the person who is presenting knows, but the person who is listening, I think to make it more informative for them, more pictures should be there of the initial presentation, imaging pictures, especially in these type of cases. They help to teach and to learn.
Yes.
Okay, and increases the chances of acceptance also if you are planning to publish. Okay, thank you. So should we move to the next speaker? Should we move to the next speaker?
Dr. Parul, sir, problem sorted
Dr.
out your
Parul, has your
problem?
problem been solved?
Okay, yeah, go on.
So again we have Dr. Parul, NMOSD and role of hormones.
Good afternoon, everyone. So my case is neuromyelitis optica, which is a which is a severe inflammatory demyelinating disease that preferentially affects the optic nerves in the spinal cord and involves severe bilateral simultaneous optic neuritis, longitudinally extensive transverse myelitis and area postrema syndrome, with majority of the patients suffering a relapsing course even with immunosuppressive and immunomodulatory treatment. So in our case, a 26-year-old female came with the chief complaints of diminution of vision in the left eye since last 1.5 months, which was preceded by neck pain, head reeling, vomiting and generalized weakness. She had a history of use of contraceptive pills for the last 2 years, which she stopped 6 months back. She became pregnant 2 months back, which was followed by spontaneous abortion 15 days back. On examination, right eye was within normal limits, and in left eye, the best corrected visual acuity was found to be counting fingers close to face and near vision of less than N36 with a grade 3 RAPT. A strabismic workup was done which showed 15-degree left exotropia with modified Krimsky test of 15 prismadiopters of left exotropia. We saw that the fundus was within normal limits, with which we came to a provisional diagnosis of left eye retrobulbar neuritis and acquired exotropia. Investigations were sent in which contrast enhanced MRI brain plus orbit showed left optic nerve thickening with T2 hyperintensities and increased post contrast enhancement, and contrast enhanced MRI spine shows subtle patchy areas of hyperintensity involving the cervical spinal cords from C2 to C4 segments. Lab investigations were sent in which we saw that NMO aquaporin 4 antibody was found to be positive, MOG was negative and APLA was negative. VEP showed prolonged latency in left eye with normal amplitude. With this, we came to a final diagnosis of left eye retrobulbar neuritis, which is seropositive NMOSD with left eye sensory exotropia. Intervention: 3 doses of injection IVMP was given under the physician's guidance, which was followed by oral steroids for 11 days along with oral calcium supplements and PPIs, but no significant improvement was seen in vision and color vision. So neurological consultation was done and the patient was started on IV immunoglobulins followed by rituximab. With this, we came to an outcome of best corrected visual acuity of counting finger 2 meters in the left eye with grade 3 RAPD. The patient is on regular follow-up with neurologist and ophthalmologist and is being given monthly injectable rituximab. This disease is characterized by a specific IgG antibody against astrocytic aquaporin 4 water channels in most of the cases, and its intensity increases the disease activity in maternal and fetal outcomes patients during pregnancy. Neuro-ophthalmological examinations of OCPs include 6 cranial nerve palsies, parietal syndrome, hemianopsia, and papilledema. Vascular complications include CRVO, CRAO, aneurysms, macular edema, and acute ischemic optic neuropathy. Isolated cases of transverse myelitis is reported after long-term uses of OCPs. Pathophysiology includes the fetoplacental unit synthesizes Th2 cytokines that causes a downregulation of maternal cytokines, increases of humoral immunity. With higher estrogen levels, there is a development of self-reactive peripheral B cells that causes increased antibody production, and that causes placental inflammation causing preeclampsia, abortions and stillbirths. It is a relapsing central nervous disease which occur during pregnancy, in early postpartum period or during lactational phases. Delayed diagnosis yield fatal outcomes. Unlike typical demyelinating optic neuritis, majority of the patient require early immunosuppressive therapy to minimize the long-term disability, and recurrences and relapses are common. In spite of aggressive treatment, visual prognosis is poor in most of the cases. Thank you.
Anything different in this particular case?
So this was a unilateral case that came to us with a history of OCP use. With pregnancy and lactating mothers coming with optic neuritis is still seen in the literature, but having OCPs might have caused this disease.
Possible, difficult to prove.
It can be something which is incidental also.
It's coincidental, not necessarily.
But yes, studies are being done to find the correlation between the hormonal therapy and NMOSD. So there have been various studies in the literature, though they are still exploring what is the exact pathology, as you have said. So it was a well-documented case and an interesting one. But yes, it can be coincidental and hard to prove, as sir has said.
One question I wanted to ask, how long did you follow, means steroid was given to this patient, did you follow the normal regimen or something different regimen was
Normal
there?
regimen was followed, that is 3 days of 1 gram IVMP followed by 11 days of oral steroid, 1 gram per
No,
kg.
did you, means it is a correlation between you and the ophthalmologist and the neurologist, okay? So once they have diagnosed, whether I'm asking you specifically, was it only for 11 days or they did more steroid was used in this case?
Ma'am, after that steroid was not used, the patient was shifted to immunoglobulins. And
So
then-
immediately they gave them immunoglobulins? No, that
yes, ma'am, neurologist opinion, they like the
started
patient was-
immediately with
yes, ma'am.
immunoglobulins.
We
Okay.
didn't see any visual improvement, so the patient was referred and they started with IV
No, what does the
immunoglobulins.
literature says actually? If you go back and see the literature of the studies, so can you, since you have read, I'm asking you, how long should the steroids be given, and then is there a cutoff level, or when do we see them and what do we see them to start with immunosuppressives? As a postgraduate student, I'm asking you this.
Ma'am, according to the protocol, 3 days of high dose IVMP and then that protocol.
Yours was something atypical optic neuritis you are dealing with.
Yes, ma'am.
Yeah. So how long do we see, is visual acuity the criteria or some other things is a criteria to change over to immunosuppressive?
Ma'am, improvement in the color vision also we take into account.
Okay, good.
Thank you, sir.
Dr. Deepti, is it the next presentation? Yeah. No, Dr. Tejasvi.
Deepti will be the next
Yeah.
one, and she'll be
Deepti.
discussing the case of acquired abducens nerve palsy. Please, Dr. Deepti.
Good evening, everyone. So I will be discussing the case of acquired abducens nerve palsy. A little bit brief about the most common cause of ischemic, that is diabetes mellitus. It has a varied presentation at difficult times of onset. One of the uncommon presentation in cranial nerve palsy secondary to microvascular ischemia. Approximately 20% of isolated abducens nerve palsies are secondary to vascular microangiopathy. Isolated abducens nerve palsy is most common form of cranial nerve palsy that is encountered in Neuro-Ophthal clinic. There can be some other causes like idiopathic or due to secondary head trauma or raised intracranial tension because of any intracranial space occupying lesions, vascular diseases, inflammatory and demyelinating conditions. Coming to my case, this is a case of 43 years old male presented to emergency with the complaint of double vision since 2 weeks, which worsens on right gaze. The patient had blurry vision and double vision in right gaze that resolves with closing either eye. He has also developed headache during that period. He is diabetic for 20 years. He is non-hypertensive. There is no any other systemic illness. There is no any similar episode of illness in the past. It is not associated with limb weakness or there is no any history of head or ocular trauma. There is no cerebrovascular accident, no altered sensorium. Patient is tobacco chewer for 15 years. He is non-alcoholic, non-smoker with normal bladder bowel habits. Cognition is appropriate for age. Best corrected visual acuity is 6.6, both the eyes, and 6 for near. Palpebral aperture within normal limit. There is no ptosis. Eyeball position, there is right eye esotropia. Extraocular movements, right eye. There is limitation in abduction. Left eye, it is free and full. Pupils were equal, normosensitive, normoreactive. There is no abnormal head posture. Bales is good, corneal sensation intact, both the eyes. Fundus is within normal limit. There is no papilledema. IOP is 14 millimeters of mercury, both the eyes. There is no other cranial nerve functions. Other cranial nerve functions are intact. This is the image showing 9 gaze. There is limitation of abduction in right eye. On investigation, blood pressure 126/78. blood glucose level was raised up to 305 milligrams per deciliter. HbA1c was found to be 12.3%, which was very significantly high. And other parameters, CBC, lipid profile, homocysteine level were also done, which were found to be normal. CT head and angiography were performed and were unremarkable. Other imagings were not significant, and patient was scheduled for OPD follow-up. Diagnosis, this is the case of acute isolated right-sided abducens cranial nerve palsy, which was most likely owing to microvascular ischemia from previously diagnosed diabetes mellitus. Concluding the case, this is infrequent presentation and diagnosis is usually delayed with the expense of ordering costly investigations. Thus, awareness that, when encountering such cases of isolated cranial nerve palsy is needed. Most of the cases get spontaneously resolved in the course of 3 to 4 months with a good control on blood sugar level. Thank you.
When would you like to investigate sixth nerve palsy in a lot more detail, like doing MRI, etc.? When would you like to do it?
Sir, so when according to the age group of the patient, and when we are suspecting any other etiology, like if it is because of trauma, then we need to investigate neurologically.
Okay, that you can get the history itself tells you whether it is traumatic sixth nerve or not. So you want to investigate more. You don't know whether what else could be the cause of the sixth nerve palsy. Here you accidentally found the sugar was high and you realized that you thought that this is related to diabetes, which may not necessarily be.
So other than ischemic causes, then we need to investigate properly.
No. Would you like to take into consideration the recovery period as an important clue
Yes,
to
sir.
your diagnosis?
Yes, sir.
What is that recovery period you look at?
So 6 months. 6 months.
6 months is too long.
4 to 6
6
months.
weeks should be more than enough.
Okay.
If in 6 weeks it does not resolve, it's probably investigatable sixth nerve palsy.
And sixth nerve palsy is something which we can't take lightly in most of the cases.
Yes, if the
The
fundus is normal and
yes,
recovery is fast,
then it's okay. But
then it's
and
okay.
one more thing which you should always remember is that sixth nerve is one of the nerves which is passing through the cavernous sinus. So involvement of other cranial nerves,
yes.
especially the third, fourth, and the fifth, which are lying in the cavernous sinus lateral wall, should
Yes, ma'am.
warrant an imaging as urgent as possible.
Yes,
okay.
ma'am. Yes,
And fundus evaluation is a must in all the OPD cases, but it is a must in sixth nerve palsy.
Yes,
because
ma'am.
this edema you should not neglect. Okay, so sixth nerve
And these
palsy.
are the other features which I was looking
Yes.
for, in the sense that when you want to investigate sixth nerve palsy, apart from the fact that it recovers within 6 weeks, if the other features are there, you will investigate even more earlier than 6 weeks.
And one more thing, that your patient was a heavily diabetic patient, like HbA1c being 12.3, and you know that the patient is a known diabetic. See, there was a surge of mucormycosis cases, if you remember, 4 years back. Okay, so mucormycosis is something which is not very uncommon in these type of patients who are uncontrolled diabetic. And sixth nerve palsy can be the first presentation sometimes in
Okay.
these cases. So yes, you sometimes need to investigate sixth nerve palsy much more in detail if the recovery, as sir told, is not as per it has to be, right?
Yes, ma'am.
Okay.
Thank you, ma'am. Thank you.
Dr. Manasi, she's going to tell us about twisted tail of a turned eye.
Good afternoon, everyone. I'll be narrating a twisted tale of a turned eye. It's not moving. A 52-year-old female patient came with a complaint of inward deviation of left eye since birth. She desired a cosmetic correction. So when we took up meticulous history, the inward deviation of left eye was since birth. It was non-progressive, non-resolving in nature. No history of diurnal variation was noted. No history of trauma was noted. No history of any previous ocular surgeries was noted. She was a non-diabetic, non-hypertensive patient, had no history of thyroid eye disease, and no history of usage of any high-power glasses. General physical and systemic examination was within normal limits. On ocular examination, head posture was normal. There was no head tilt or face turn which was noted. Right eye was orthotropic and left eye showed 70 prism diopters of esotropia in all 9 gazes on Krimsky test. Worth 4-dot test showed left suppression with no stereopsis. On ocular examination, right eye had BCVA of 20/20, and rest of the anterior and posterior segment examination was normal. She had an NS2 grade of cataract. Left eye, however, had a vision of 20/800 and a near vision of less than N36. She had NS1 grade of cataract. The fundus, as far as we could visualize, was normal, and the ocular movements were restricted. This was the condition wherein there was absolutely no abduction which was noted. Adduction was present but restricted. Basically all the gazes, there was restriction in all gazes. So we were thinking of, it looked like a strabismus fixus. It could be myopic strabismus fixus or maybe an post-LR palsy strabismus fixus. So the patient underwent MRI brain and orbit. And what we did find out was very surprising. She had on MRI scan, the LR muscle was shown to be absent. So this was a case of an absent LR muscle. However, we took an intraoperative confirmation of an absent muscle, and also on-table force duction test was done, which showed a tight MR. So moving on, a two-stage surgical procedure was planned, wherein first stage we did an MR hangback recession, and 2 months later, the patient underwent a vertical rectus transposition. A full tendon rectus transposition of superior and inferior rectus was done. This is the post-op, immediate post-op image. When we did a review of literature, very few articles are published on an isolated case of LR muscle absence. Many of the absence of LR muscle or any other muscle was associated with any craniosynostosis or craniofacial abnormalities, but very few articles mention isolated absence of the muscle. After 6 months, she had a minimal esotropia with abduction restriction. So what are my take-home messages? First of all, a congenital absence of a muscle is possible cause of a congenital concomitant strabismus, and this can be present even in absence of craniofacial abnormalities. So when we deal with such a case, we should keep this in mind. Secondly, the radiology has a very new emerging role in strabismus these days, wherein in case of concomitant strabismus, it helps us in looking into the condition of the muscle present. So in cases of a missed muscle, any muscle entrapment, any condition like thyroid orbitopathy, it can give us more information regarding the same, so it can help us in planning. Thank you.
Do you do dynamic MRI?
Yes, sir. We didn't do it in this case, but we can do a dynamic MR to see the...
So, have you heard of dynamic MRI? Anyone? The postgraduates? No? Never heard of it? Can you explain to them?
So basically, the muscle contraction is noted during the MRI procedure. So we can we can comment on contractility or
the thickness of the muscle is measured during abduction and during adduction of a given muscle. Usually it is done for lateral rectus or for medial rectus, not necessarily for the vertical recti. It's not very accurate. So ask the patient to look to the right and then look at the thickness of the muscle at the thickest part, and look to the left and look at the muscle at the thickest part and compare it. It's very useful in some of these cases to do a dynamic MRI of the extraocular muscles. When you write for MRI, you must specify what exactly you want. Just don't write MRI brain, MRI extraocular muscle. What are you looking for in extraocular muscle MRI? Are you looking for restriction? You are looking for the absence of muscle? What are you looking for? That's important to specify. And if you have radiology in your own close by, you go and see during the procedure. It helps you to, the radiologist also feels comfortable that you are there. And the patient feels even more comfortable because you are there, although you are not a radiologist. Okay, good, well presented.
And it is an interesting case indeed. I have a similar patient. She has bilateral limitation of abduction. I have done her first stage surgery a month back with a large MR recession, but still there is not much improvement, so I have planned for transposition next month. So it's an interesting case, and yes, I must congratulate your mentors. They have done a very good job.
Usually you see even in congenital absence of lateral rectus, when you isolate the area, you will see some fibrotic tissue.
Tissue, yes.
And you can just recess that, you can resect that fibrotic tissue and get some effect.
Effect, yes, sir.
Okay. Actually, congenital absence of lateral rectus is quite uncommon and has been rarely reported. I have come across cases of absence of inferior rectus that is more
commonly seen. More commonly
we have seen inferior rectus absence. Okay, thank you.
Thank you, ma'am.
Should we move on to the next speaker?
Dr. Samarpita Dhar.
Pituitary macroadenoma. 9.
Who is the audio-visual guy? Okay.
Good afternoon to one and all. I am Dr. Samarpita Dhar, presenting to you a case of pituitary macroadenoma. Pituitary adenomas are slow-growing and benign tumors of the anterior pituitary, which are classified on the basis of their size and functionality as functional, non-functional, and macro or microadenoma. Clinical features include mass effect like headache, vomiting, gradual and painless diminution of vision, color desaturation, etc. And diagnosis is based on endocrinological profile based on the various markers of pituitary and radiological investigations like CT and MRI. A 41-year-old female came to the ophthalmology OPD complaining of frequent changing of glasses in both eyes since 1 year and a diminution of vision which was gradual, painless and progressive in nature in the right eye since 3 months, followed by a dull aching headache in the bifrontal area since 3 months. There was no history of any trauma or nausea or vomiting. And she was a known case of hypothyroidism since 7 years and 1 year ago had an episode of irregular menstrual cycle based on which she was investigated and raised prolactin levels were found and physician consultation was done and she was given tablet cabergoline and was said to continue tablet thyroxine for hypothyroidism. On ocular examination, the vision in the right eye was 624, which was not improving, while in the left eye it was 66. Color vision was within normal limit and IOP was also within normal limit. The extraocular movements were full, free and painless in all cases, but the confrontation test showed a restriction in the both temporal fields. The anterior segment examination was within normal limit and also the pupil was pupil showed direct and consensual light reflex to be present. The fundus examination in the left eye was within normal limit, but on the right eye showed a temporal pallor. So based on the history and examination, a provisional diagnosis of bitemporal hemianopia was made and differential diagnosis included the optic chiasma disorders such as pituitary adenoma, which shows functional adenoma like abnormalities, and non-functional adenoma showed pressure symptoms, and in craniopharyngioma it showed headache with focal neurological deficits and seizures, and AC aneurysm, which if ruptured shows the worst headache of life, and meningioma, which has features similar to the craniopharyngioma but has an extraaxial mass on dural attachment. Investigations were ocular, The ocular investigations were HVF24-2 and an optical coherence tomography. Systemic investigations showed a raised serum prolactin and a decreased serum cortisol. And the visual field showed a asymmetrical bitemporal hemianopia, and OCT RNFL showed a right-eye RNFL segmental loss temporally, which coincided with the temporal pallor, and the macula OCT was within normal limit. Our suspicions were confirmed on MRI brain plus orbit, which showed a heterogeneously enhancing mass on axial MRI T1 weighted, which was 20 into 27 into 29 mm in size, and in parietal MRI, it showed a well-defined cellular and supracellular mass, which was all suggestive of pituitary macroadenoma. So based on this, a final diagnosis of bitemporal hemianopia secondary to pituitary macroadenoma, which was causing an optic chiasmal compression, was based on the confrontation test, visual field analysis, and MRI brain in orbit. So based on which an ophthalmological intervention was to refer to endocrinology, who suggested the continuation of tablet cabergoline, which was a dopamine agonist for control of hyperprolactinemia, and neurosurgical referral for transphenodal dissection of the tumor. So here we can see the patient following up in her OPD from October to November, when transphenodal dissection of the pituitary adenoma was done, but unfortunately she was lost to follow-up. So the clinical implications suggest that advising MRI brain and visual field is extremely important, and an early diagnosis of mass defect is also important, and multidisciplinary approach, including an endocrinologist and neurosurgeon, is important. These are my literature review. Thank you so much.
What happens to the stereopsis in these patients with pituitary lesions?
Sorry, sir. Can you repeat the question?
No. Is the stereopsis likely to be affected or probably not?
Could be affected, sir.
Could be affected. That's why I said that if you know orthoptech, you will know the results. Where exactly is the fibers of stereopsis interconnected? Posterior corpus callosum.
Yes.
Much higher up and nothing to do with pituitary area. So they may have reduced vision, but stereopsis may still be absolutely normal. Okay, even if you cut the chiasma, they may have normal stereopsis. Okay?
Yes, sir.
So, any patient around the age of 40 who comes to you with frequent change of glasses, which he has never done in the past, particularly his presbyopia, is not happy with it, think of something else as the cause for his problems. Check his intraocular pressure, check his fundus carefully, and make sure that there are no other issues causing this problem. She had frequent change of glasses, right?
Yes, sir.
So there is no reason, unless you are a cataract surgeon, first thing you will do is remove the lens and say, okay, fine, go, everything is all right. Otherwise, you will check for specific things in any patient who complains of frequent change of glasses at 40.
Also, the blood sugar levels should be checked, because sometimes fluctuation in the blood sugar levels of a diabetic patient can also lead to this frequent change of the glasses. Okay.
Yes.
So I think this was a pretty straightforward case as such. Bitemporal hemianopia you found in confrontation itself. They found itself in the OPD in the confrontation that the patient had bitemporal hemianopia. So it was pretty straightforward and a well documented case. Thank you. Now we'll move to the next.
Have you done any other hormone assay?
Sir, serum prolactin levels were checked, which was found to be marginally raised, but it was not as raised as in functional adenomas. So we suspected that it was a non-functional adenoma, which was causing a compression on the pituitary stalk, thus decreasing the dopamine levels, which has an inhibitory effect on prolactin. So because of inhibition of dopamine, the prolactin was raised, not because of its functionalities. And serum cortisol levels were decreased, which meant that the pituitary was decreased, it was not functioning properly.
Where do the macular fibers go in pituitary area? The macular fibers have a different orientation. They go windingly towards the cortex, correct?
Yes, sir.
So at the pituitary level, what happens to them?
Sir, as much as I know that because in when the occipital cortex is involved, the
No, don't go up to occipital cortex. I am asking you much before the occipital cortex, what happens to the macular fibers? Macular fibers don't remain in the center at all. During transition from optic nerve to the lateral genicular body, the macular fibers go round and round like this. There's a specific reason for why they do that. Any clue? No, never mind. No problem. You are from AIMS in Nagpur, is it?
yes, sir.
Okay. You will get to know gradually.
Yes, sir.
No problem.
Thank you, sir.
Next.
Exotropia, Akshay Kumar. Is he there? I didn't hear you.
This best, you have to find out the best speaker.
Good afternoon, everyone. I am going to present a case of exotropia. Introduction. Intermittent exotropia typically begins before the age of 5 years. The exodeviation becomes manifest during times of visual inattention, fatigue, stress. Parents of affected children often report that the exotropia occurs late in the day. Intermittent exotropia may remain stable, resolve, or progress with time. So here is the case detail. 27-year-old male presented with the complaint of outward deviation of other eye, right eye more than left eye since last 7 years. It was associated with headache. There was no history of diplopia, no history of patching, no history of ocular trauma, no history of any neurological illness. Birth history was within normal. On ocular examination, uncorrected visual acuity was 6/9 in right eye and 6/6 in left eye. Best corrected was 6/6 in both the eyes. Extraocular movements were full and free in all the gazes. Cornea and lens were clear. Fundus examination was within normal. So here is a pre-op 9-gaze photograph of the patient. Corneal light reflex was 25 to 30 degree nasal to the limbus. So sensory examination was done, and sensory examination was 4-dot test and Bagolini striated glasses were done, and they showed that there was right eye suppression. On motor examination, head postures were normal. There was no any head tilt. Hirschberg test, corneal light reflex was between the pupillary margin to nasal limbal border, 25 to 30 degrees. On cover and cover test, on covering left eye, right eye was taking fixation, which was central, steady and maintained. On uncovering left eye, it was again taking fixation, so it indicated that left eye was dominant. So next, prism bar cover test was done, and deviation was for near it was 45 prism diopter, and for distance in the primary gaze it was 45 prism diopter. So there was no pattern. So differential diagnosis can be intermittent exotropia, essential exotropia, or sensory exotropia. Since it was adult onset, there was no diplopia and separation. We came to the diagnosis of final diagnosis of intermittent exotropia, which later converted into decompensated and converted into right eye divergent squint, which was Calhoun stage 4. So for treatment, surgery was done, and in right eye, lateral rectus muscle resection was done 9 mm, and medial rectus resection was done 6.5 mm. So here is a 2-week follow-up photograph, 9-gaze photograph. Extraocular movement was full and free. Corneal reflex was central, and there was no improvement or Randor test. So next is the 9-gaze photograph of 2 months follow-up. Here extraocular movement was full and free. Corneal light reflex was central, but patient has gained 400 seconds of arc stereopsis at near. There was no improvement for distance stereopsis. Take home message: always in a patient of any type of squint, always first we do the refractive error. Proper sensory and motor evaluation should be done. Aim of treatment is to achieve stereopsis. Conservative management is done up to Calhoun stage 2, and surgery is done if there is manifest exotropia, that is stage 3 and 4. Thank you.
Just one basic question I'm asking. What is the significance of this 9-gaze photographs? What do it implicates to you, or what do we learn from this? Looking at a 9-gaze photograph for a strabismus is the same thing as reading a visual field for a glaucoma surgeon. So can you tell what all things we infer from that?
From 9-gaze photograph, we can see if we can check if there is any progression, or after surgery if correction is there.
Just not 9-gaze photograph you told, no, preoperative. When you're seeing, what all things do we see in that? What all inference we get?
We see the deviation.
Because you have shown so many 9-gaze photographs, so you would have understood something and given those. So what are those things we see?
In
Or that photo only speaks a lot of things to you. So what are those points we should see for?
It indicates it is taken in all the 9 gauges. So if it changes, deviation is seen is on all the gauges. If there is any type of restriction, limitation, on subsequent follow-up we can look for that. Any improvement is there or not.
You have written there is left eye suppression, correct?
Right eye suppression. Sir,
You attach any significance to that, or you ignore that? Okay, go forwards. Go to the Worth-Ford dot test picture. There. What is that? Worth-Ford dots. Green, you are shown 3 green. Green is in front of left eye.
Left eye.
Or right eye.
Green is in front of left eye, sir.
It could be right eye also. It depends on which red and green glasses you buy. Okay, green in front. So the red is in front of right eye, and green is in front of left eye, and right eye is suppressed.
Yes, sir. Red is in front of right eye and green is in front of left eye.
Okay. So right eye is suppressed even though left eye has a peculiar refractive error.
Your right eye had a refractive error,
Yes,
as you
ma'am.
had shown in the previous slide.
Yes,
+1 sphere, +1 cylinder, he had shown with
180.
180. In the right eye, there was a refractive error.
Yes, ma'am.
So it could be anisometropic amblyopia also.
Yes, sir.
1 cylinder is sufficient enough to give rise to
But but the best corrected visual acuity which he is getting is 6/6 with the refraction.
Yes, 6/6, but there is no, there could be a binocular interaction abnormality.
The degree of exotropia, I think he had, what was the degree of exotropia your patient had?
45 prism diopters.
Something is not adding up here to me. You see, if it is just a simple intermittent exotropia which is going on to constant exotropia.
It went to constant exotropia.
Now it has gone to constant exotropia. At least for near he will be straight, no matter how much is the distance exotropia is. For near he will be straight. If you force them to look at the near object and ask them to look at it both the eyes, they will straighten out. So 90% of the tropias are only exotropias, intermittent exotropias. Correct?
True.
So it's only very rare that you get truly alternate exotropia.
No.
Anyway, the whole point is to emphasize that you be very careful in assessing. Even now he is not binocular for distance, correct? Which means that it will come back. The squint will come back over a period of time.
In the end, he has mentioned that there was an improvement in the stereopsis in the post-op period. So that was the near stereopsis you were talking.
Near stereopsis.
But the distance which you mentioned, please can you show the slide? It was 16 inches.
400 seconds of arc. Good improvement in stereopsis is there, but for distance, you don't measure the distance stereopsis, do you? You have not measured it.
For distance, sir, for near there is improvement, but for
No, for near there is an improvement of stereopsis.
So the distance is mentioned at 16 inches. The near stereopsis, the distance usually which we take is like 40 centimeters or 50 centimeters.
That's okay. 16 inches
16
is not too
inches
bad.
is
For distance, you measure with the Mentor's distance stereoptor.
the random, even the distance random which we do.
See, what happens is these things, for distance, there is no fusion, and they gradually break up. And few near also they break up, even though you have operated.
So even the FD2 test which we do is at 3 meters. I think you should correct the distance here. It might not be 16 inches. It might be 25 centimeters or 40 centimeters. The distance, that is a typographical error, I guess. So that needs to be corrected. And yes, as sir has emphasized, that exotropias are notorious sometimes for an exodrift. There might be a recurrence, especially in these type of cases where there is a suppression, a gross suppression. The good thing is that your patient has gained some stereopsis now. Let's see, I think he should be advised some exercises in the post-op period also to keep them aligned.
Yes, ma'am.
Okay, thank you. Who is next?
Molly and Krishna Narala.
Krishna Reddy.
Krishna Reddy.
8 and a half.
8.5 syndrome.
8.5 syndrome.
8.5 syndrome. One is here.
He is here. He is here. He has taken the opposite side. I think we can do that. The next speaker can keep themselves ready in the opposite side.
Next, Saurabh Raj now get ready on that particular side.
Hello. Good afternoon, everyone. Today my topic is about 8.5 syndrome, which is a rare neuro-ophthalmic presentation due to lacunar infarct as a cause. Coming to the introduction, these brainstem lesions are typically rare due to the presence and they are present with difficult distinguishing clinical features due to the involvement of various nuclei and various pathways that coordinate sensory and motor functions. Here we present one such case with right horizontal conjugate gaze movement palsy along with ipsilateral peripheral facial nerve paralysis indicating 8.5 syndrome. The patient is 62 years male, comes with the complaints of diplopia, which is sudden in onset, non-progressive and binocular. Horizontal separation of images is more towards the right side. It is associated with giddiness, headache and vomiting. Patient also complains of difficulty in closing his right eye, deviation of the mouth to his left side. He is a known case of type 2 diabetic mellitus and systemic hypertension since 5 years on irregular medications, and he is non-alcoholic and non-smoker, and family history is not significant. General physical examination showed elevated blood pressure of 170 by 120 millimeter of Hg, and the remaining vitals are within normal limits. Systemic examination, apart from the cranial nervous system, which shows 7th cranial nerve palsy symptoms, the rest of the systems are within the normal examinations. Ocular examination shows erect head posture with the orthophoric eyes, and the facial asymmetry is present. And right eye shows lag ophthalmos, and right side loss of nasolabial folds, and in addition to the deviation of the angle of mouth to the left side is present. Bell's phenomena is intact, and there is no RAPD. Extraocular movement examination showed right gaze palsy, right adduction restriction with left abducting nystagmus, and left adduction restriction. These are the pictures showing right-sided facial palsy element type and right gaze palsy, right adduction restriction with left abducting nystagmus, and the intact vertical movements of right eye and the left eye. The convergence were also normal. Coming to the vision, and color vision and field vision shows normal, and visual acuity is 6/6 in both eyes. Next, anterior and posterior examination. Anterior examination of right eye shows lag ophthalmos, and rest of the findings are normal within the both eyes. This is the MRI brain scan showing hyperintensity foci with diffusion restriction and ADI reversal in the tegmentum of the right hemipons, suggesting of acute lacunar infarct in the tegmentum of the right hemipons confined to the basilar artery. The blood investigation profile showed elevated GRBS level and elevated total serum cholesterol level, and the rest of the is like serum electrolytes, liver profile, and everything was in the normal limits. And the provisional diagnosis is right 8.5 syndrome due to lacunar infarct in the dorsal tegmentum of right hemipons. My intervention is routine eye care with lubricating eye drops and eye ointment at bedtime and occlusion of the right eye. Next, physiotherapy to improve the facial nerve palsy symptoms. And patient was referred for the neurological review, and for which he was treated with anticoagulants, antiplatelet drugs, insulin, and antihypertensives for the systemic conditions. Later, patient is discharged with oral medications and advised neuro-rehabilitation and regular follow-up. A follow-up done was for 3 months, and for every 2 weeks, patient is reviewed, and patient showed improvement in the facial palsy symptoms. Facial palsy symptoms were improved earlier than the improvement in the extraocular movements, and the diplopia is symptomatically improved. These shows the extraocular movements after the 3 months follow-up. Coming to the literature review, this is a rare case which so far 27 cases have been published. Among those, 18 were due to vascular, 4 were due to autoimmune such as multiple sclerosis, and 3 due to hemorrhagic stroke, and 1 due to gained cellular arteritis and pontine tuberculoma. Rarely, trigeminal neuralgia with 8 syndrome has also been described. These are ischemic vertebrobasilar strokes, nearly comprises of 23% of all ischemic strokes of the brain, and brainstem infarcts are responsible for among 11%. Of these ischemic basilar infarcts, 27% occur in the pons. The main pathology is leading to pontine infarction is basilar artery arthrothrombosis or perforator diseases. Pontine infarcts limited to the tegmentum are mostly caused by the small vessel disease or are seldom associated with basilar artery stenosis. Embolism is usually associated with infarct in other parts of the brain and is an uncommon cause of isolated pontine infractions. The etiology related to these lesions include hypertension is the most common cause of 73.5%, diabetes of 48%, cigarette smoking include 30%, and alcoholic consumption is 40.2%. Hyperlipidemia constitutes for 20.6%. Next, clinical implications and take-home messages. As the stroke is the most commonly seen cases, and it is the 30 million cases are involved worldwide, and India is experiencing 1.9 million cases in 2019, and it became the 4th most common cause of death in the recent times. So, the interpretation of the eye movement abnormalities and clinical and ophthalmological examination plays a clinical more important role for the precise diagnosis of the lesion and management, thereby decreasing the morbidity and mortality outcomes. And the MRI plays a major important role, and it has an advantage over CT in the detection of these lesions in the acute ischemic stroke. And the only preventive measures available for this is strict diabetic mellitus and hypertensive control. Thank you.
So it is 8.5 syndrome.
Why are calling 8.5 syndrome?
7th nerve plus 1.5 syndrome.
Yes.
Now, how do you know which side is the lesion?
Right PPRF and
right gaze is paralyzed,
yes,
so right paramedian pontine
paralyzed, so
reticular
we
formation
right
is
PPRF.
affected. Okay? If the right-sided paramedian pontine reticular formation is affected, the left adduction of the right eye is restricted. Means what?
Total.
The adduction, adduction of the right eye to the left is restricted, correct? Which means that the impulse goes from 6th to the 3rd nerve, or it comes down from 3rd to the 6th nerve.
6th to 3rd nerve to medial longitudinal.
It is an ascending impulse.
Medial longitudinal.
It's not a descending impulse. That is one of the characteristic features of medial longitudinal fasciculars, is that the lesion, the impulse ascends from 6th nerve to the 3rd nerve, not the other way around. Okay?
Yes,
so 7th nerve is affected and 1.5 syndrome is there, so it's called 8.5 syndrome.
Yes.
Nothing great about it. Yes?
Yes, sir.
With the MRI, all these things become child's play.
Yes, sir.
You don't need to use your brain.
Yes, sir.
Yes?
Clinical.
Do we need to surgically intervene in these cases?
For
The
lag
squint
ophthalmos,
part?
we can intervene, like, apart from that, not much more.
Okay. Thank you.
Thank you.
Sarabhraj Nag,
Are you ready?
Sarbaraj Nag. Yeah, please start.
I think we will request the next speaker, Dr. Aruja, to be ready. Dr. Aruja? She's not there.
Good
Then
afternoon, everyone.
Dr. Srija, be ready.
The two-sibling model of understanding personality theory in causation of Squint. Presenting author myself, Dr. Saurabh Rajnak, co-author Dr. Partha Roy. Now the background. The role of personality traits of children in the causation of the Squint was first suggested by Dr. von Nudun and his colleagues. But until recently in 2007, when Dr. Partha Roy threw light on his paper, nothing substantial was known. Von Nudun exemplified with a model of two siblings, a 8-year-old girl and her 6-year-old brother, both having same amplitude of hypermetropia, that is +5 diopter, but reacted differently when confronted with stress of excessive accommodative effort to see clearly. Dr. Roy hypothesized that the girl had a stable personality as she confronted stress of excessive accommodation and saw clear but squinted, but the boy had a neurotic trait of personality as he instinctively avoided stress and relaxed accommodation to remain orthophoric but saw blurred. In the foregoing presentation, we would present a similar kind of model sibling as that of von Nudun and testify whether von Nudun's Roy hypothesis, when considered conjointly, are proven to be true in our model. A 4-year-old child with her elder sister and mother came to IOPD with complaint of deviation of eye, which is alternating from 1 year of her age. The mother also told that the child's grandmother has deviation of her eye and she was worried if it is hereditary or not. She also informed that her elder daughter is quite reserved and touchy, but her youngest daughter is more talkative, thoughtful and lively. The mother also wanted her elder daughter to undergo ophthalmological checkup. On examination of the younger child, the visual acuity unaided 6/12 both eye. The rest of the anterior segment is within normal limit. Full cyclopegic refraction was given, shows that right eye -1.25 spherical 6.6, left eye -1.5 spherical 6.6, N6 both eye. On evaluation of the squint, alternating cover test with prism showed 45 prism diopter alternating divergence squint, which is near is equal to distance, which is corrected with spectacle. Primary deviation is equal to secondary deviation in all 9 gauges, AC by A ratio 3:1. Synaptopore reveals decreased binocular single vision. There is no diplopia, nystagmus noted. FDT of lateral rectors of both eyes come to be negative. There is no AV pattern, no disorderly vertical deviation noted. So our provisional diagnosis is refractive, accommodative, concomitant, alternating exotropia. On examination of the elder child, visual acuity 6/9 partial both eye. Rest of the anterior segment is normal. On refraction -1.5 spherical both eye 6.6. On uncovered test, there is no foria detected. Now, the two children from the same family, having same gender, same socioeconomic status, same family history, and almost same degree and type of refractive error, one having exotropia and other one orthotopic. The only difference between the two children is a difference in their personalities. So we decided to go for a personality test for both the children with JEPQ questionnaire, which is assessed by neuroticism and stable dimension. On examination, the younger child, who is more lively, scored less than 12, suggestive of a stable personality, but her elder child, who is more reserved, touchy, who scored more than 12, suggestive of neurotic trait of personality. Both the child were given full refractive correction and advised to come for a regular follow-up at 3-month interval. Outcome is the individual with a stable personality trait are more prone to develop squint, whereas those with the neurotic personality traits are prone to remain orthoptic. These are my literature review. They are asked to follow up every 3 to 6 months and further evaluation and management of their condition. Now, what is the clinical implication? The most accepted theory of causation of concomitant squint is Dondos accommodation theory. But here we saw Dondos accommodation theory cannot alone explain the causation of concomitant squint. Therefore, this presentation proved Dondos theory superimposed with Dr. Nudun Roy is what may future holds for us. Until then, a lot more research is necessary. Thank you.
Tell me, personality trait disorders is something to do with the intelligence. The more intelligent children tend to have esotropia, and less intelligent children tend to have exotropia. That's well known. That again is related to the control of the eye by the attention center in the parietal lobe. If the parietal lobe attention center is strong, they probably are likely to be more intelligent. So this term I had never heard of, refractive accommodative exotropia. I've heard of refractive accommodative esotropias, but never heard of exotropia. You don't get refractive and non-accommodative possible, but refractive and accommodative, you cannot have exotropia. You can only have esotropia. Something wrong in terminology, but anyway, that's up to you to decide.
Okay. And I think you have just seen one case, and it's difficult to conclude anything by just looking at one case. So you came across only one case like this.
Thank you, sir.
And you are thinking.
Ma'am, there is also a study by Dr. Partha Sarathy Roy, which include 60 total patients, which showed the same kind of result, but more number of cases required to establish this type of causation.
Yes, it's better to be presented as a case series or a study. Thank you.
Thank you. Thank you all.
So I think the next two speakers, Dr. Aruja and Dr. Shrija, are they here?
No.
No. So Dr. Rishabh, are you here? Please be ready. And Dr. Devu Krishna. Dr. Devu Krishna, if he is not there, then we have one more last speaker added, Dr. Ruchi Agarwal. Please be ready on the dais.
She's the last.
She is the last.
Rishabh Narula.
Yes, start.
Go on.
Good evening, everyone. I will be presenting a case of cortical visual impairment. CVI has been defined as a bilateral visual impairment in the presence of a normal ocular examination, reduced visual acuity or subnormal visual performance, and evidence of damage to the posterior visual pathways. Visual acuity, contrast sensitivity, color perception, and visual fields may all be affected to varying degrees. Causes include premature birth, perinatal insults, hypoxia, ischemia being most common, CNS infections, hydrocephalus, neonatal seizures, and hypoglycemia. Most common systemic associations are neurological conditions, hydrocephalus being a major cause, and as children with CVI usually have multiple concurrent disabilities, multidisciplinary approach is required for early identification and treatment initiation. The patient, 1.5 years old, 1.5 months old, in NICU graduate, presented with a history of neonatal sepsis and hydrocephalus to the ophthalmology OPD for evaluation. And parents gave a positive history of eye contact with mother, but absent social smile. It was a full-term emergency LSCS in view of fetal distress. The child had meconium-stained liquor, cried soon after birth, but developed respiratory distress, and was admitted in NICU and was on ventilation. There's history of neonatal sepsis, neonatal jaundice, and 2 episodes of hypoglycemia as well. So on examination, the child was not fixing and following point source, was responding well to sound, preferring right gaze. No evidence of nystagmus was noted, and on dilated fundus examination, fundus findings were normal, and the cycloplegic refraction showed a +6 diopters hypermetropia. Child was advised to vision stimulation activities and asked to follow up. Investigations which were done on NICU admissions were CT brain, which showed an intraparenchymal hemorrhage and which was extending into the intraventricular region. And also MRI brain showed an infarct of the left corona radiata, that is periventricular leukomalacia. Neurosonogram also confirmed the findings. Second visit was at 3.5 months. The patient was not compliant. The parents were not very compliant with the vision stimulation activities. Visual acuity was still wandering fixation. Blink reflex to bright torchlight was there, but there was no menace. no fixing even in darkroom illumination, and a diagnosis of cortical visual impairment was made. The child was lost to follow-up till 9 months of age when he followed up, and there was a functional visual assessment done. Visual alertness still was not fixing following objects. There was a delayed response in dim illumination, and was fixating only to well-lit bright objects up to a 5 centimeter area, and there was no face regard. Visual sphere was only 10 centimeters, that too in dim illumination, and the visual fields were delayed, and color preference was there, which was yellow. Developmental milestones showed delay in all the modalities: gross motor, fine motor, communication, and socio-personal. Significant history was he had a history of hydrocephalus, but there was no surgical intervention carried out because there was no signs of any raised intracranial pressure. Only the monitoring of head circumference was done. Father was in complete denial of the disease and was not ready to follow up regularly. And mother was overburdened, and she was not very regularly following up with the vision stimulation exercises. A CVA resolution charting was done, and the child was found to have a final diagnosis of cortical visual impairment, phase 2, range 1 to 2, which is a very primitive stage of development, and he was way behind his peers of the same age. Vision stimulation exercises that were given were light pad activities, play mat activities with contrast borders and with different textures. Increased contrast on caregiver's face was introduced by throwing light or using bindis for women or a bright hat for males. And parents were counseled again, and integrated activities with tactile and auditory stimulation were carried out. Speech therapy was carried out, and physiotherapy was started, as the child was also not able to sit. Then the child was further evaluated, classified according to the International Classification of Functioning and Disability and Health from WHO, and various strengths and weaknesses were noted, and the weaknesses were worked upon. On follow-up, parents were still inconsistent, and gradual improvement was there on follow-up visits, but still the child needs a lot improvement in his skills. There is a limited literature available on research for CVI, but mostly in most of the places it's followed like there's no specific treatment given for CVI, and doctors usually wait for CNS maturation, and they say that it will improve as the child grows older. But literature has shown that there is significant improvement if early vision therapy is started in these children. Role of pediatrician also cannot be neglected in sending the patient to a pediatric ophthalmologist as early as possible. So prompt ophthalmological evaluation can help in diagnosing other neurological conditions associated with CVI. High suspicion should be kept in NICU graduate. Prognosis also depends on the site and age of insult. There are poorer outcomes noted in children with insult to corona radiata, especially seen as periventricular leukomalacia on neuroimaging. Early initiation of multidisciplinary rehabilitation has definite role in visual and overall outcome. Future research in VEP, functional MRI, and diffusion tensor imaging to study cortical activation patterns will be of great help. Thank you.
A typical case of CVI does not usually show any CNS abnormality. In the absence of demonstrable CNS abnormality, the child is still not able to see. That is what is described as cerebral cortical visual impairment. Everything else is normal. There is no abnormality of the brain. But here you have shown some abnormality of the brain. So the diagnosis of cortical visual impairment itself is doubtful. Did you get my point?
Yes, sir.
So it is secondary to a problem in the brain. So you cannot call it as cortical visual impairment or cortical visual deficiency when you have demonstrated a change in the brain. You got it?
Yes, sir.
Thank you.
Okay.
So we don't have Dr. Devu Krishna. So we'll just move on to the next speaker, Dr. Ruchi Agarwal.
Last one.
Yes.
It's not here. They added.
Good evening, everyone. I'm going to talk about an atypical presentation of Foster-Kennedy syndrome due to neurocysticercosis. The triad of ipsilateral optic atrophy with contralateral optic disc edema and ipsilateral anosmia in the presence of a space-occupying lesion in the basofrontal region is termed as Foster-Kennedy syndrome, and in the absence of this lesion is called pseudo-Foster-Kennedy syndrome. Foster-Kennedy syndrome has been reported most commonly due to frontal lobe meningiomas, additionally with craniopharyngiomas and pituitary adenomas, and rarely with neuroblastoma, nasopharyngeal angiofibroma, and plasmacytoma. Here we are presenting a case of ipsilateral optic disc atrophy and contralateral impending disc edema attributed to the presence of an ipsilateral cysticercus granuloma. Our patient was a 13-year-old male who presented to us with history of sudden onset abnormal movements of the left side of body 1 day back. A family member had noticed sudden shaking movement of arm and legs that had lasted for 3 minutes, followed by lethargy afterwards. The past history and family history were not significant. There was no history of visual complaints or fever, chills, night sweats, or history suggestive of motor or sensory deficits. On general examination, the patient was conscious, cooperative, and well-oriented to time, place, and person. The vitals and systemic examination was within normal limits, and neurological examination revealed bilateral dependent reflexes were brisk, plantar reflexes were normal, and cranial nerves and sensory examination were within normal limits. On ocular examination, the vision was 6/6 in both the eyes, near vision was N6. The positive finding was that the patient had RAPD grade 1 in the right eye, and intraocular pressure measured by ORA at 12 p.m. was 12.2 and 17.3 millimeters of mercury. The anterior segment examination was within normal limits. On fundus examination, in the right eye, media was clear, the optic disc shape and size was within normal limits, margins were distinct, there was temporal disc pallor seen, and the temporal and inferior neuroretinal rim thinning was present. In the left eye, media was clear, disc shape and size was normal, the disc was hyperemic with intact margins, and blood vessel tortuosity was present. CDR in the right eye appeared to be around 0.6 and around 0.3 in the left eye. The patient's total leukocyte count was 11,500. Rest hemogram was within normal limits. On CT scan, a 0.8 into 0.9 centimeter ring enhancing lesion was seen in the right parietal lobe with perifocal edema. On Humphrey 24-2 visual testing, a reduction of the superior visual field was present in the right eye. Optical coherence tomography, RNFL revealed RNFL thinning of superior, inferior, and temporal periphery in the right eye. The vertical CDR was 0.7 in the right eye, 0.5 in the left eye. Cup volume revealed that the cup volume in the left eye was less, that is 0.10, that is there was fullness of the optic disc present. The patient was started on treatment according to the Infectious Disease Society of America. He was started on carbamazepine, prednisolone, albendazole, acetazolamide, and calcium and vitamin B12 complex. So our patient had ipsilateral optic disc pallor with contralateral impending disc edema. Neurocysticercosis, neurological lesions can present as parenchymal cysts more commonly and rarely as ventricular cysts. In India, the most common ocular site is the adnexa. In the Western world, it is posterior segment. The reported cases of visual loss due to neurocysticercosis has been most commonly due to post-papillary edema optic atrophy. Wilbrand and Sanger have reported 1 case of monoocular temporal hemianopia and 2 cases of homonymous hemianopia as well. My conclusion is that ophthalmological examination is necessary in every patient with neurocysticercosis. Along with adnexal and anterior segment examination, a dilated fundoscopy is vital. Foster-Kennedy syndrome, although commonly associated with a frontal lobe lesion, can manifest in atypical forms in such patients. Thank you.
Okay.
Thank you.
Okay, thank you.
Thank you, sir.
So, I think that marks the end of this session also.
All the presentations were very good, and may I request Dr. Shantan Gopal to give a line of concluding address.
Only thing I would like to say is you all have done a good job, but you remember you are all exceeding the time. 4 minutes is 4 slides. Remember, 4 minutes, 4 lines per slide, 4 slides. That's all. In those 16 sentences, you must convey exactly what you want to say. We are not here to listen to lecture, but we are here to have a clarity of your thought presented in 4 slides. You all have done a good job, but you need to practice. Even now when I go for presentation, I practice for 1 hour before I present. Because I may say some words which are of no use or which are highly thought-provoking. All those things have to be kept in mind. I think you have done a good job, but you will improve a lot later on. Thank you. That should be enough. Thank you.
Thank you all. Now we can start on with the next session. The next session is on glaucoma and trauma. I'm again a panelist.
I can move now.
Thank you.
Thank you.
Thank you.
Thank you.
I think Praful sir has taken. For the next session, may I quickly invite Dr. Richa Abhishek Gupta, Dr. Anu and Dr. Nikita Berry. And I hope the speakers are ready. The speakers are Dr. Pankhudi, Dr. Ishan, Dr. Vibha, Dr. Asmita, Dr. Arushi, Dr. Resham and Dr. Vanshika. I hope everyone is ready. Yeah. Yes, I think we will ask many questions, okay? Come, sit.
अच्छा फोटोग्राफ में हम भी Dr. Pankhuri, are you there? Dr. Pankhuri Varma? No? So the next speaker is Dr. Ishan Goyal. Yeah, please come and be ready with your slides.